It's a privilege to introduce Dr. Sana Quddus. Dr. Quddus comes to us actually from Pakistan, where she went to medical school in Lahore, and she did her internal medicine residency and fellowship in pulmonary critical care here at Henry Ford Hospital. And she's been part of the pulmonary hypertension team with Dr. Hector Cajigas, who has grown this section to be a very robust and providing advanced care for this unique population. So without further ado, Dr. Quddus, thank you so much for being part of our program.
Thank you, Marwan. Good afternoon. I was telling Marwan I'm notorious for talking too much, so I'm just going to get started so that we can begin with the presentation. So, I chose this title is Portopulmonary Hypertension, a curable disease. I wanted to emphasize this because contrary to what we had seen in the past, where patients with portopulmonary hypertension had very poor outcomes, were not transplant candidates, this has changed in the modern era now. We know that there is a select cohort of patients who, when treated with vasodilator medications, will improve their hemodynamics, and they will do so to an extent where they can be successfully transplanted, and after the transplant can be weaned off of all vasodilator medications in a matter of a few months. So who are the patients who have such a successful course is going to be the basis of my talk so that we can identify those patients and improve their outcomes. So the goal of my talk will basically be to answer 4 questions for the audience. So what is the natural history of the disease? How do these patients do? What is their survival? And the next thing would be, how will we screen these patients and treat these patients so that the transplant can be done safely? What happens after the transplant? Do they have a survival that's comparable to patients who do not have portopulmonary hypertension? And what happens with their vasodilator therapy? Are they able to be successfully weaned off of vasodilators or not? And the last question is, what if a patient is not a transplant candidate? Should they still be treated with other options such as vasodilator medications or not? So portopulmonary hypertension, quite simply, is pulmonary arterial hypertension that occurs in the setting of clinical portal hypertension. So emphasis is placed on this being an arterial hypertension, not venous hypertension. And in the Western countries, most of the cases of portopulmonary hypertension will occur in patients who have cirrhosis. However, it can occur in the presence of non-cirrhotic portal hypertension as well. When you look at large series from Baylor as well as Mayo Clinic, the prevalence in patients who are being evaluated for a liver transplant is 5.3 to around 8.5%. We get very concerned about these patients because we know that there is significant mortality at the time of the transplant. These patients, if they are untreated, will not do well at the time of the liver transplant in the OR or within a few days of the transplant. They will go into right ventricular failure. As the awareness of portopulmonary hypertension is increasing, it is rapidly becoming one of the most common forms of non-idiopathic pulmonary arterial hypertension. So according to the 2008 WHO data point classification, as well as the new 2013 NICE classification, patients who have portopulmonary hypertension are placed in the same WHO group, which is WHO group 1, as patients who have idiopathic pulmonary arterial hypertension. The reason for this is that the pathology is very similar. In fact, pathologically, these patients are indistinct from patients who have idiopathic pulmonary arterial hypertension. What all the patients in group 1 have in common is an arteriopathy, which means that there is something wrong with the pulmonary circulation. There is an obstruction within the pulmonary circulation, which causes a high pulmonary vascular resistance and causes the right ventricular to become diseased and dysfunctional with time. It's important to distinguish this group from other causes of pulmonary hypertension. Group 2 disease are patients who have left heart disease. Group 3 are patients who have any kind of lung disease or hypoxemia. And group 4 patients usually have history of chronic thromboembolic disease. So before we go any further, I wanted to talk about the common causes of elevated pulmonary pressures in patients who are being evaluated for a liver transplant. So the most common cause is not going to be actually portopulmonary hypertension. It's going to be a high flow state, which is seen in around 35 to 40% of the patients who will go for a liver transplant. So these patients will have hyperdynamic circulations. They have a very high cardiac output. What's important is that they have a normal pulmonary vascular resistance. They have a normal wedge, and the only thing that is going to be elevated is going to be the PA pressure, which is a reflection of the high cardiac output. There's nothing wrong with their pulmonary circulation. The other common group is going to be patients who have pulmonary venous hypertension. These are patients because of the liver disease or because of associated renal or heart disease will have a high wedge. There is increased central volume, and again, the cardiac output and the PVR is again going to be normal in these patients. Then there is a group of patients who obviously have portopulmonary hypertension, and the distinguishing feature in these patients is again the arteriopathy and the high PVR. The diagnosis of pulmonary arterial hypertension and portopulmonary hypertension requires a right heart catheterization. There is no way that on a screening echo that you can distinguish between different forms of pulmonary hypertension. When the right heart catheterization is done, what will usually be seen with the hyperdynamic state is a very high cardiac output, a low wedge, and a normal PVR. Excess volume, again, is going to be with a high wedge, a high pulmonary pressure. The PVR can be slightly elevated in these patients, and the parameter that we use in order to distinguish this PVR, increase in the PVR from patients who have arteriopathy, is the transpulmonary gradient. And we'll talk about that a little bit later as well. And the last group is patients with portopulmonary hypertension. Again, these are patients who have pathological changes in the pulmonary arterial system and are going to have a high PVR. The cardiac output in these patients initially is going to be increased with trying to compensate for the disease and the high afterload. However, with time, the PVR falls as the right ventricle becomes more and more dysfunctional. So this is the definition of portopulmonary hypertension. It's a hemodynamic definition. It was put forth by the European Respiratory Society and as well as the US Consensus Study Group in 2004. To define portopulmonary hypertension, you need to have clinical evidence of portal hypertension, so either ascites, splenomegaly, or varices, combined with a mean PA pressure, which is more than 25, a PVR, which is more than 240, and a wedge, which is normal, which rules out venous congestion as a cause of the pulmonary hypertension. Before we move forward, I wanted to talk about certain parameters that we look at within our group to distinguish arteriopathy from other features. And that is, again, the PVR, which takes into account the wedge and the cardiac output. We're seeing how much of the elevations in the mean PA pressure are being caused by the arteriopathy. The transpulmonary gradient of more than 12 is abnormal. That means even by taking the wedge into account, there is an element of obstruction that is not completely explained by the venous stasis. And then you have the diastolic gradient of more than 5, which is also considered abnormal. It's the PA diastolic pressure minus the wedge. These are all parameters that we look at before we say that a patient has portopulmonary hypertension. This is the classification of the severity of portopulmonary hypertension. It's based on the degree of elevation in the mean PA pressures. Mild is as long as their mean PA pressure is under 35, and we know that these patients can go forward with a liver transplant without any negative implications. And patients who have moderate to severe portopulmonary hypertension are those that have an elevation in the mean PA pressure from 35 to 45 or more than 45. This is again a classification that was put forward by the European Respiratory Society as well as the US Consensus Study Group. So the first case of portopulmonary hypertension was actually described in 1951, and then it was documented on autopsy findings as well. What Mance and Craig described was a woman who had stenosis of the portal vein, When they did an autopsy, she had basically all the pulmonary arterioles lined with in situ thrombosis. They also had extensive endothelial and smooth muscle proliferation, leading to tumor-like or plexogenic lesions. This is very similar to what we see in patients who have WHO group 1 disease or idiopathic pulmonary arterial hypertension. Again, these are normal pulmonary arterioles, which are very distensible, and they allow blood to flow easily. And this is an end-stage patient who has advanced vascular lesion, has obstruction to the blood flow in the form of plexogenic lesions. This is the kind of lesion that you would see in a patient who has portopulmonary hypertension. So what is the pathophysiology? Why do patients who have portal hypertension develop portopulmonary hypertension? Well, there has to be a genetic susceptibility because not everybody who has portal hypertension will develop portopulmonary hypertension. And then there's a second insult which causes the injury. That insult is in the form of circulating cytokines and mediators, as well as shear stress from increased blood flow. In looking at the genetic risk factors for portopulmonary hypertension, this is a prospective study that was done in 2009. They looked at genotyping for 1,000 different single nucleotide polymorphisms and found relevant association and significant association with all these genes. Looking at the vascular mediators, there's a recent article in 2010 that compared different cytokines and different mediators in patients who had portopulmonary hypertension versus patients who did not have any portopulmonary hypertension or had uncomplicated cirrhosis. What they found was that these patients are deficient in prostacyclin synthase. We know that prostacyclins and prostacyclin analogs are important for maintaining vasodilation and inhibit platelet aggregation. There are increasing levels of endothelin. Endothelin is a vasoconstrictor, and there are increasing levels of interleukin-6. So these are the three main pathways that have been well described in patients with WHO group 1 disease. These are also the three main pathways, the therapeutic targets that we use our common classes of vasodilator medications for. Important one out of these for portopulmonary hypertension is the prostacyclin pathway, and we do treat our patients with prostacyclin analogs. The nitric oxide pathway, for targeting this pathway, we use either the sildenafil and other phosphodiesterase inhibitors or inhaled nitric oxide. And the endothelin pathway, for which we commonly use the bosentan or the Letairis. So what happens once the pulmonary circulation starts developing this kind of an obstruction? What usually happens is that the RV initially tries to compensate, so it hypertrophies and tries to pump blood against a high resistance. After a while, because of increasing pulmonary vascular resistance, the right ventricle cannot do its work anymore. It starts getting dysfunctional, it's going to start dilating, and as a result of that, there is a severe decrease in the cardiac output. Unfortunately, most of the time that we diagnose portopulmonary hypertension, the patients are in this phase, and they are already in right heart failure. Again, the hemodynamics of these patients show that initially, early on, the PVR is going to be high and the PA pressures are going to be high. The cardiac output is going to be maintained, and that's why the patient does not become symptomatic. As long as they can maintain a cardiac output, they will not have symptoms. However, over time, as the PVR continues to increase, the cardiac output begins to suffer and begins to decline. And this is a patient who is completely decompensated and end stage where the RV is dilated. It cannot function, and signs and symptoms of right heart dysfunction, for example, pedal edema, ascites, and poor forward flow will develop.
You maybe cardiac output relatively level, but in our patients with liver disease, they tend to go up higher. So your left side SVR drops off dramatically, high cardiac output. The right side has high cardiac output, and then are these effects secondary to vasoconstriction to prevent, high flow, because you have high flow to the right side now.
Sure.
And it gets worse and worse. So instead of that curve going down, it's more like an up and then coming down.
For specifically for cirrhotic patients. Absolutely. So the PV, when we look at these patients, when they are end stage, what we see is that the cardiac output is not as high as would be expected. Their cardiac output will start declining. So if they started off with 8 liters, with time, as the PVR increases, we will follow these patients over time. They will go to 7, 5, and this tells us, although it seems like that they have maintained their cardiac output, it's actually a decline from their baseline. So we do follow that very closely. And that would be reflective. If the cardiac output drops from 8 to 7 to 5, that would be reflected by the increase in the PVR. Although the pressures will not be that abnormal because the cardiac output is high, but the PVR is going to start getting abnormal. So again, the symptoms and the clinical picture of these patients is related to 2 things. It is related to poor forward flow as well as signs and symptoms of volume overload. I think what's interested in patients who have portopulmonary hypertension as opposed to other WHO group 1 diseases is that we know that these patients do not typically present with exertional dyspnea or chest pain. These patients are going to present with lower extremity edema, ascites, things that can be confused with advanced liver disease. And hence, before we were doing screening echoes, a lot of time this diagnosis was being made in the OR because it was being missed. So this is the landmark study that was published in Liver Transplantation. Kroka and his colleagues basically looked at retrospectively at all the patients that were available to look at in the published data, as well as according to the Mayo Clinic experience. What they found, what they were trying to look at and retrospectively analyze was, if patients have untreated portopulmonary hypertension, then how do the pulmonary hemodynamics correlate with peri-operative cardiopulmonary mortality? So what they found was, in total, they had 43 patients who had untreated portopulmonary hypertension. This is published in 2000, and they went for a liver transplant. In 65% of these patients, the diagnosis was made in the OR. So this was intra-op hemodynamics. And in 65% of the cases, the patients had at least moderate degree of portal hypertension, which means that they had mean PA pressures of more than 35. The pulmonary hemodynamics that they looked at was the mean PA pressure, the PVR, the cardiac output, the wedge, and the transpulmonary gradient. So all this was available for them to analyze. What they found was, looking back at the hemodynamics, they were able to identify very well-defined cutoffs. So if a patient had a mean PA pressure of more than 35 at the time of a liver transplant, their mortality on the table in the OR and within the same transplant admission was 48%. If the PVR was more than 250, then their mortality was again 55% in the OR or within the same hospital admission. Whether the cardiac output was more or less than 8 liters really did not make difference, was not statistically significant. The transpulmonary gradient being high, and again, the transpulmonary gradient is the mean PA pressure minus the wedge. So if it's high, it means that there is some obstruction in the pulmonary circulation. If the transpulmonary gradient was more than 15, then again, the mortality was significant. And this is in the OR or within the same hospital admission as the transplant. Sure.
They don't seem to classify those as an and. You know what I'm saying? It's true and unrelated. Like, are the 6%, those 18 patients who died in the hospital, are those patients with PA pressures that are over 35?
They were actually able to identify those patients. So this is the next slide. So they were actually able to find out, was it just an isolated increase in the mean PA pressure that was responsible for the high mortality, or was it the high PVR as well? So if your mean PA pressure, I'll go over the entire slide again. So the Mayo Clinic, based on the data that was presented by Kroka, presented these intraoperative guidelines for all patients undergoing liver transplantation. According to this guideline, if you had a mean PA pressure of less than 35, regardless of everything else, then you can go ahead with the liver transplant and your mortality is 0. But if it is above 35, between 35 and 50, then you have to look at the PVR. So you have to distinguish those patients from high cardiac output states. So if your PVR is more than 250, then you have a high mortality. But when they looked at patients with high PA pressure and a normal PVR, their mortality was not increased from some, as long as you take into account, paying close attention to the volume status, making sure that because of the high cardiac output state, they're not going into heart failure. As long as the PVR is normal, you're not at high risk for mortality. If it's more than 50, then the case should be canceled. So if it is higher than 35 and the PVR is high, the case should be canceled. If the mean PA pressure is more than 50, and at this point they said regardless of the PVR, you cannot get mean PA pressures of more than 50 with a normal PVR. So if it's that high, then the case should be canceled. This is very similar to how we clear patients. These are similar to the guidelines that we have in terms of clearing patients for a transplant as well. So, how do patients do when we follow them over time? We have to realize that when we look at prognostic markers or therapies for patients who have portopulmonary hypertension, a lot of it is extrapolated data from patients who have idiopathic pulmonary arterial hypertension. So we use a lot of these markers which have been well documented for idiopathic pulmonary arterial hypertension, but some of it has been documented for patients with portopulmonary hypertension as well. So we know that patients are at high risk of progression of disease and at risk for poor outcomes if they already have developed clinical evidence of RV dysfunction, if they're progressing very rapidly, they're symptomatic at rest, they have high BNPs, the echoes show significant right ventricular dysfunction. Either the RV is significantly dilated or the function of the RV, as is assessed by the RVEF or the TAPSE scores, we look at different parameters. If it is low, then the outcomes are poor. At the time of hemodynamics, in addition to everything, if you have a high right atrial pressure and a low cardiac index, this is associated with poor outcomes. When we look at prospective data and try to identify risk factors for portopulmonary hypertension, we know that it is not related to the severity of portal hypertension. So somebody who has very severe portal hypertension, which does not mean that they will have somebody who has severe portal hypertension does not mean that they have severe portopulmonary hypertension as well. The other thing is it does not correlate with severity of the liver disease. So just because you have a high MELD score or you have a high child PRO class does not mean that you are at high risk for either development or progression of portopulmonary hypertension. So survival in patients with portopulmonary hypertension has always been a little bit difficult to tease out. This is basically because death can occur because of two main reasons. A major reason for death could be complications of liver disease, which are non-cardiopulmonary, so renal failure, GI bleed, and things like that. Or death could be from right heart failure. In order to look at survival for these patients, there are three main registries that we can follow. One is the French registry. The other is the Mayo Clinic data. These are both retrospective analyses. And the third one is the REVEAL registry. REVEAL registry is different because it's the largest series of patients we have. It's also prospective. So we'll talk about this a little bit later. So let's go to the French registry first. If you look at data from the French registry, there were around 154 patients that were retrospectively analyzed. These are patients who were sent to the French referral center, and they are unique in the sense that anybody who gets diagnosed with portopulmonary hypertension in France has to go to the same center. So the data, at least in that way, is comprehensive. You can see that from a portopulmonary hypertension standpoint, these patients were sick. Majority of them were class 3 or 4 symptoms. They did have high PVR, although the cardiac index was maintained. What these investigators found was that the 1, 3, and the 5-year survival in these patients was not bad. So patients with portopulmonary hypertension, this doesn't look that bad, 85, 73, and 68%. But we have to remember, looking back at the data, that most of the patients in this group had not very severe or advanced liver disease. I believe the majority of them were actually child class A patients. What they also found was what was prognostically significant when they did a regression analysis was the presence of cirrhosis, the severity of cirrhosis, or the cardiac index. They found that patients who had cirrhosis versus patients who had non-cirrhotic portal hypertension, their survival curves were quite different, and that cirrhosis and the severity of cirrhosis contributed significantly to death in this group. This is conflicting data to what was presented the same year by the Mayo Clinic. Mayo Clinic also retrospectively looked at their data of around 74 patients between 1994 and 2007. What they did was they then categorized the patients according to the treatment subgroups. So they looked at patients who received no therapy at all, no vasodilators, no transplant, patients who did receive vasodilators but was not followed by a transplant, versus patients who were treated with dilators and then transplanted. We see that the 1-year mortality, if you do not receive any therapy, is around 50%. So this is very different from the French registry. Over here, half of the people are already dead at 1 year. The 5-year survival, if you do get vasodilators but no transplant, is 45%. So significant improvement just with vasodilator medication. And the other thing is if you get transplanted, the 5-year survival does improve further as well. So the authors concluded that some therapy is still better than no therapy. Even if you're not going to transplant them, you should give them vasodilator medication with the aim to improve their survival. So these are the survival curves for the different group, and of particular interest is this group, which went without any prostacyclins. They were not pre-treated and went straight for a liver transplant. And these patients, there was significant mortality at the time of the transplant if the PA pressures were not controlled prior to the liver transplant.
What are the treatment goals?
The treatment goal would be to bring the mean PA pressure to less than 35 and to normalize the PVR to make it less than 240. So
that's who they're talking about. Those are the people who actually make it to transplant.
True transplant. Absolutely. So then we look at data from the REVEAL registry, which is a prospective multi-center registry in the US. 55 different centers in the US contributed data to the REVEAL registry. It's also the largest registry of patients with portopulmonary hypertension. 174 patients between 2006 and 2009. What they did was they were trying to compare patient outcomes and management trends in patients with portopulmonary hypertension in the modern era versus patients who have idiopathic pulmonary arterial hypertension. And what the authors were able to find was, and this is prospective data, was compared to patients who have idiopathic pulmonary arterial hypertension, at the beginning, the portopulmonary hypertension patients have better hemodynamics. And I think it kind of goes with the fact that they have a higher cardiac output than patients who have idiopathic pulmonary hypertension. On the other hand, when they looked at the survivor curves, the survival, which was 2 and 5 year survival for these patients, was worse than patients who had idiopathic pulmonary arterial hypertension. So despite having better hemodynamics, these patients died sooner than patients with idiopathic pulmonary arterial hypertension. Another thing that was found from the REVEAL registry was patients who have portopulmonary hypertension, they are less likely to be treated, as opposed to somebody who has idiopathic, and a lot of the PH centers are treating those patients. Patients who have portopulmonary hypertension, they are less likely at the time of enrollment of the REVEAL registry, they were less likely to be on treatment. So again, the same thing, comparing the idiopathic PAH patient to the portopulmonary hypertension patients, you can see that the mean PA pressure is better, the PVR is lower, the cardiac output is higher, and majority of them were in the same New York Heart Association class, which is class 3. The survival curves are very different. The 2 and the 5 year survival for portopulmonary hypertension is 60 and 40%. So 5 year survival, according to the largest registry, the largest contemporary registry, at least in the US, the 5 year survival is 40%. Again, very different from the data that we had gotten from the French registry. Again, freedom from event in terms of hospital admissions. For portopulmonary hypertension, we know that these patients are going to be sicker, they're going to be in the hospital more, and will use more resources, healthcare resources, than patients who have idiopathic pulmonary arterial hypertension. One of the objectives of the REVEAL registry was to differentiate between outcomes within the different subgroups, WHO 1 group subgroup. So what they found was, for all the patients who have pulmonary arterial hypertension, the worst thing to have is the portopulmonary hypertension group. Their survival compared to all the other groups was worse. When they did regression analysis, they found that portopulmonary hypertension is one of the independent risk factors for mortality. So these are practice guidelines that were proposed by American Association for the Study of Liver Disease in 2005. Prior to that, like I mentioned, most of the cases were diagnosed in the OR, right heart failure in the OR was not uncommon at that time. So according to the practice guidelines, every patient who is being evaluated for a liver transplant should have a screening Doppler echo. They recommended the Doppler echo as an excellent screening test. However, the results need to be confirmed by a right heart catheterization. And patients who are found to have moderate to severe portopulmonary hypertension, moderate to severe are again patients where the mean PA pressure is more than 35 and the PVR is more than 250. These patients, their pressures need to be effectively controlled before we can list them or transplant them. So screening echoes as a screening test, how they detect pulmonary hypertension is by assessing the right ventricular systolic pressure. This is by looking at the tricuspid regurgitant jet velocity. Most of the centers in the US are using a cutoff between 40 and 50. Mayo Clinic proposed a cutoff of 50. We at Henry Ford are using a cutoff of 40. This is based on institutional data, institutional experience, but we have seen that with the cutoff of 40, we're able to identify and not miss any case of moderate to severe portopulmonary hypertension. And again, needs confirmation. It has a very good negative predictive value. A screening echo, more than 90% will have a good negative predictive value. But the positive predictive value is poor because, again, it's just showing the RV systolic pressure and it's not giving you a good picture of the entire hemodynamics. So this is also data from Mayo Clinic where they looked at the accuracy of a screening echo. They looked at around 1,200 liver transplant candidates. They all had echoes done as part of screening evaluation. Out of these patients, 100 of them had RV systolic pressures more than 50. This was followed by a right heart catheterization within the same week. What they found was 65% had portopulmonary, and again, 35% of the liver patients had a high cardiac output state. So there is moderate correlation between what you find on the right heart catheterization and what the echo tells you, and the correlation gets poorer as the pressures become higher. So the right heart catheterization allows you to confirm the diagnosis. It will tell you the severity of the disease. It will identify the patient that needs to be treated. Once you start them on treatment, it will allow you to see if there is a response to therapy, whether further therapy needs to be added or not. What we do over here and what is recommended is to avoid vasoreactivity testing in these patients. Vasoreactivity testing is done to see if they are candidates for treatment with calcium channel blockers. And it is it's contraindicated in patients with portal hypertension. I'm sure the audience knows because of the risk of causing an increase in the portal pressures. The calcium channel blockers are known to cause an increase in the hepatic venous pressure gradients. So we do not in our cath lab do vasoreactivity testing for these patients. So this is the screening algorithm and the treatment algorithm that is proposed by the Mayo Clinic and very close to what we follow over here. So if your screening echo shows that a RV systolic pressure of 50, 40 for Henry Ford, that means it's a good screening test. The patient can be reassessed in 12 months. That rules out pulmonary hypertension. If not, then the patients are followed by a right heart catheterization. If on the right heart catheterizations, your mean PA pressure is more than 35 and the PVR is more than 240, then the patients are started on vasodilator medications. If that's not the case, if the mean PA pressure is less than 35, the PVR is less than 240, then we will clear them for a liver transplant. Patients who do have mild pulmonary arterial hypertension with the mean PA pressure that is between 25 and 35, if they are on the waiting list, we try to reassess them every 3 to 6 months, because in a lot of patients there is very rapid progression of disease. So somebody can go quickly from having mild disease to moderate severe disease at the time of transplant. The recent advances in vasodilator therapy, sure.
So just go back to one slide back, sorry. But the, so you said that you follow them if they meet the middle criteria, which is 35 and greater than 240. But those are the ones we kind of know or in the past, but the ones that we worry about are these high mean pressures with low PVRs that don't get screened, and then when they present with that middle thing in the OR. That's what I'm concerned about. How do we monitor for that?
Sure. Anybody who has a high RV systolic pressure and on a right heart cath, even if the PVR is normal, once they've been seen by us and we've done the right, we will follow them. So in our clinic, we see them every 3 to 6 months. So, okay. So anybody who, this is the only group that we are reassessing after 20 months. As long as their screening echo was fine, we usually don't follow them. If there was anything wrong on the screening echo, we will see them. So again, our understanding of the hemodynamics that occurred during the liver transplant has improved significantly over the last few years as well. We know that what happens in the OR during a liver transplant is that within minutes of the reperfusion of the graft, there is an increase in the cardiac output. Mostly the increase in the cardiac output is 10 to 20%, but there are patients where the increase is up to 100%. So the cardiac output can go from around 5 liters to 15 liters. This causes an elevation in their PA pressure. All this is important because if somebody already has a vasculopathy, already has a high PVR, then their right ventricle is under a lot of stress and strain. It's pumping again, it's required to pump blood against a very high resistance, so it will fail. It will dilate and the patients will develop right heart failure. So that's the situation that we're trying to avoid. Yes.
Comment on this graph. The technique and the approach to the liver transplant and what kind of organ and how they managed it may change this graph quite a bit.
Okay.
And when we evolved from bicable anastomosis to a piggyback anastomosis, that has changed quite a bit. So the changes became more dependent on the quality of the graft and whether people have collateral when you clamp the coral vein.
Okay.
Then when people started doing bicable without bypass, then they had to do volume loading. And in addition to that, the coral vein is clamped all this time. Then there is a different reperfusion event. So it's always good to tie this diagram to the technique and the approach that this center has, what kind of patients they have. Because it will present different scenarios. But we always see these elevations, but it varies dramatically based on the technical approach and the anesthetic management as well.
Okay.
This is a good thing to remember that.
Sure.
That's a good point. I wasn't aware of that. So do you guys, if we have any of these cases who we have treated and we have accomplished to be in that group that can be transplanted, does that weigh any role in regards of how you decide your technique?
Yes.
It does.
So we'll do cable still, but we have to do a bypass. So it changes how we do it. We know about it ahead of time, but we kind of.
And sometimes you have to debate on the quality of the graft as well. Because people will not do well with a bad, or not bad, but extended bacteria graft where the reperfusion events will be more dramatic. Because the reperfusion is not just for the medical, right?
Cytokine and
cytokine release and all these things, both from the liver and from the gut.
Yeah.
The other thing is, I think one of the things you brought up is that the heart, you see a lot of changes in the pressures of a measure, but in addition to that, as Dr. Ramsey wrote in that paper, is that the right heart doesn't function normally even in normal positions.
And I know for sure that this is the piggyback technique. So this is, I thought it was neat. This is actually data from Egypt. And it was prospective data, so I thought it was worth mentioning. So these were 10 patients who had mild portopulmonary hypertension versus normal controls. And like you had mentioned, even the normal controls with the right ventricular EF just slightly goes down at the time of reperfusion. So what they did in the OR was they had continuous TEE monitoring. They had a PA catheter in place, and they measured the right ventricular EF. This is at induction. This is end hepatectomy. This is before portal unclamping. This is 5 and 30 minutes post-reperfusion, and this is closure. So even patients who have mild portopulmonary hypertension, patients that we would clear for a liver transplant, they will have a decrease in their right ventricular EF much more marked than patients who don't have any portopulmonary hypertension. But all of these patients, it was, they clinically tolerated this decrease in the EF very well without any damage to the graft or without any negative implications. So in terms of vasodilator medications that are available for treating these patients, we now have a fair number of agents that we can use in these patients. If you look at over the last 2 decades, there have been at least 25 different randomized controlled trials that have been done, unfortunately all excluding patients with portopulmonary hypertension. So all of the randomized clinical studies have excluded these patients. So clinical trials with vasodilator medications targeting portopulmonary hypertension is very uncommon and unusual. Most of the data that we use is experimental series, case series that have been presented and have been encouraging and successful. Before we start a patient on vasodilators, we do a risk assessment. That assessment is based on their functional capacity, their hemodynamics from the right heart catheterization, what their right heart looks like on an echo, and then what the MELD score is. Is it somebody who needs a transplant right away, or is it somebody who can wait for a little bit? Based on these criteria, if there is a sicker patient who is rapidly declining, we will offer them intravenous prostacyclin therapy right away, as opposed to somebody who has relatively better hemodynamics and a better functional status, where we will first try a trial of oral vasodilator therapy, and if they don't respond, we can start intravenous therapy. We don't always do that, but because of the complications associated with delivery system of the prostacyclins, that is a common trend. The drug that has been used most frequently in patients with portopulmonary hypertension is epoprostenol and Flolan, and that is the one that we have the most data and experience with. So the 3 classes of vasodilators that are commonly used are again the prostacyclins, which are Flolan, Remodulin, and Iloprost. These drugs have very short half-lives. They have to be given by a central venous catheter. The endothelin receptor antagonists, bosentan and ambrisentan, that block the endothelin in a non-selective or selective manner. And then we have the phosphodiesterase inhibitors, which increase the availability of nitric oxide within the lungs, such as sildenafil and tadalafil. A little bit about the Flolan and the epoprostenol, since a lot of our mutual patients are on this therapy. So in addition to being a very potent vasodilator, pulmonary and systemic vasodilator, it also has inotropic effects. So you will see improvement in cardiac output. It also has anti-proliferative effect. That is why after being months and years on treatment with Flolan, some people will have reversal of their pulmonary arterial hypertension. The delivery system is complex. It has to run 24 hours a day. There are complications. Rate is quite high related to complications with the line, such as infection, thrombosis, or abrupt disruption, in which case you can have very severe rebound pulmonary hypertension and right heart failure. And also thrombocytopenia is a common complication and adverse effect, which becomes of significance in patients who have liver disease. So like I said, there is no randomized controlled trial to look at Flolan, its effect, but we do have case series, and 5 different case series that will pool together or combine together show that there are significant hemodynamic effects of epoprostenol. They will cause a decrease in the mean PA pressure an improvement in the cardiac output, and a reduction in a PVR. So they are strong agents and they are effective in bringing the pressures down. Do these pressures or hemodynamic changes translate into improved outcome for the patient is the question. I'm going to talk about 3 retrospective analyses looking at the effect of epoprostenol as well as other vasodilator medications in terms of getting patients transplanted or improving their survival post-transplant. The first is retrospective data from University of California, San Francisco. They were looking at patients retrospectively who were treated with epoprostenol, had improvement in their hemodynamics, and were then transplanted. All of these patients, there were a total of 19 patients who were treated after screening over a period of, I believe, 10 years. They were able to find 19 patients who were treated. Out of them, all of them had an improvement in their hemodynamics. However, out of the 19 patients that were treated, half of them died while being treated. Out of the ones that survived, their hemodynamics, only 2 of the patients, their hemodynamics improved sufficiently so that they could be transplanted. So if you look at this data that came out in 2007, it's not very encouraging. The same year, data from Baylor, looking at their patient population. The treatment was again mostly prostacyclin and epoprostenol, a 10-year retrospective analysis. They were able to find 30 portopulmonary hypertension patients based on screening echoes and right heart caths. Out of them, 20 had moderate to severe portopulmonary hypertension. Out of the 20, 16 were treated and 11 were actually successfully transplanted. The average duration of treatment with vasodilators before a patient could be transplanted was 7.5 months. And after the transplant, half of the patients were taken off of the vasodilator medication, and it took 9 months to take them off. So it's a slow process. So the Baylor, if you look at the Baylor data as opposed to the University of California data, I think they were doing a much slower wean of their vasodilator medication. Okay.
That's why larger dropouts were
because of that.
Since at that time frame, we had no oral pulmonary hypertension exceptions, and they were very severely restricted regional review board. They were not able to get them transplanted faster.
Okay.
Whereas they can do that in Texas.
Absolutely. I think, and they have mentioned that extensively, the data from Baylor, that in Texas, once a patient has been transplanted and, has been on vasodilator treatment, every 3 months, they will get a reassessment of their MELD score and they will get significant exception points. So because of that, they were more successful. So there is a clear-cut difference in survival curves in patients who responded to vasodilator therapy and were obviously transplanted versus patients who did not have any response. These patients who did not respond to vasodilator therapy had a very poor prognosis. This is data from University of Wisconsin. The agents used are a little bit different. This is Remodulin combined with sildenafil. The total, again, retrospective data, but the total number of patients who had moderate to severe portopulmonary hypertension were 11. All of them had improvement in their hemodynamics. All of them were transplanted. And post-transplant, 65% of them were off of vasodilator medications. So University of Wisconsin had a 100% success rate using a combination of Remodulin, which is in the same group as Flolan, and sildenafil. Looking at just oral vasodilators, again, they're used less commonly than prostacyclins, and the data is less. However, I thought out of all of the case series and the data that we have, I feel like this is worth mentioning, the data we have for Letairis. There were 13 patients, all of them on monotherapy with Letairis. And what they found was that in 5 out of the 13 patients, Letairis by itself was able to normalize the PVR, and these patients actually got transplanted. So I think it's good data the first time that we have for an oral agent. I think the data behind phosphodiesterase inhibitors as a monotherapy is a little bit lacking. It's not as robust as Letairis, although there were improvements in different parameters, but those were very short-term improvements and were not sustained. I thought this was interesting. It's a review of combined organ transplant for patients with portopulmonary hypertension. So patients who have moderate to severe portopulmonary hypertension and their pressures have not responded to vasodilator medications. There were 10 cases so far. This is data presented at Pittsburgh. And they underwent combined lung liver transplant or combined heart lung liver transplant. So 6 of the patients, the first 6 patients went for combined lung liver. The last 4 patients are combined heart lung liver transplant patients. If you look at survival in these patients, the 5-year survival was reported to be around 45% as a group. If you look at the incidence of right ventricular failure, it seems like the incidence is much higher when you do a combined lung liver versus a heart lung liver transplant, and the authors believe that this is because of the RV. The RV is so dysfunctional by the time these patients are so sick and not responding to vasodilators that the success of just doing a combined lung liver is, you don't see the encouraging results from that. So other intra-op considerations that are important in these patients are monitoring. These patients, what's been recommended is continuous TEE monitoring, as well as obviously we have the PA catheter in place. What happens if a patient you started on develops a pulmonary hypertensive crisis? Data is strongest for inhaled nitric oxide as well as intravenous prostacyclins. And again, what we talked about, mild exception points for patients who are on the waiting list. Since we know that the mortality is high on the waiting list with these patients and the pressures can increase over time. And then while we're waiting for the transplant, we need to see them back in clinic again and again. This is the screening algorithm at Henry Ford. Again, we are using an RV systolic pressure of 40. Again, if the echo does not show that, then you're cleared. You can come back in 12 months. However, if it is more than 40, then you need a right heart catheterization. And as long as your mean PA pressure is less than 35, and there should be an and here, and your PVR is less than 240, you can proceed with the liver transplant. This is our pulmonary hypertension group.
CVP less than 16, right? That's an official rule. 15. CVP has to be less than 15 in addition to those parameters, right?
You mean the wedge pressure? Sorry. Yes, yes, the wedge pressure. Yes. So the definition of yes.
Thank you. That's a great way to outline that for us. When you have a patient who has been pre-screened, you get on the table and their wedge is greater than 17 or 18, how is that the person who has pulmonary hypertension look when their fluid overload? I guess my question.
Clinically,
And that's the decision. That's oftentimes the decision that we have to make, because it's someone who hasn't had a right cath
Sure.
before, and they're really having their first right heart cath, you know, as we're getting them ready for transplant.
that should never happen though, right?
Right. But
Okay.
I mean,
Okay.
but it does.
According to the new guidelines, right?
Right, but even so, I mean, you know, if maybe in those 12 months, it could be,
Sure,
you know,
sure.
it could develop.
Okay.
So.
I think this is what you're asking me. So let me go back. There are parameters that you can look at to distinguish how much of the elevation in the pressures is from volume versus an obstruction in the circulation. You look at the transpulmonary gradient, or you look at the PVR. If the, let's go back. Let me go. let's look at these numbers. So these are the three things that you will look at that time. If the patient has evidence of volume overload and has an elevated wedge more than 15, then these three parameters will help you sort that out. If they have a high wedge and wedge is the only thing that is causing the high pressures, then your PVR should be normal. If your PVR is abnormal, then there is some vasculopathy there. If it is less than 240, then everything is explained by the high wedge. The transpulmonary gradient, the cutoff that we use is 12. If the difference between the mean PA pressure and the wedge is more than 12, again, there is something going on in the pulmonary circulation. There is an arteriopathy. And the other thing that we look is the diastolic gradient, the difference between the PA diastolic pressure, and the cutoff for that is 5.
I think we should eliminate this one.
You can call us. One of
a good idea, but I guess in the end, the question is that you have to make those decisions.
No, we do it on the phone with you. So
Yes, we are available 24/7.
Yeah.
Give us a call.
because, it's not an easy answer. There have been occasions where you find these high wages, and still, when you make your calculations, it still sounds like you can meet criteria by numbers, but you have to remember, these patients, sometimes you have a wedge of 30, and then you make your calculations, and yes, your PVR is low because you still have a high catechoptic state as well.
Yes.
Which is a number to be divided by. But at the end of the day, you don't want to transplant someone who may be high output failure. And sometimes imaging may be of help to you as well to see how the echo looks like in that precise moment. So I think after what we have learned, sometimes it's much better sometimes not to dare to transplant these cases if there are major questions about what is going to happen because the peri-operative mortality is just so high that it's hard to catch up. But again, that's what our service is for. We're 24/7, so you can call us and we can walk through all this. I know it gets complicated, but we don't want to lose a graft, we don't want to lose a patient either. So we try to make the best effort. And although Sana is saying very wisely to use potential vasodilators in the OR, we have to understand that you may have just an effect during that time. During that time, they may be transient and use nitric oxide, and that's something you're going to get rid of later on. And you need to move this patient into longer-term therapy. Sometimes you cannot even dare to say this is what we're going to do during the operator time, despite being proposed by others because it's not practical later on. So some of those decisions have to be made on the spot.
I think if your right heart catheterization shows numbers, which this is at the time before initiating the surgery, I think it should be canceled. I think the data behind using intra-op operative vasodilators and inhaled nitric oxide and things of that nature is for patients when they're already on the table, you open them up. And even if you look at that data, most of the patients died. Even when they use it, if you're past that point, then obviously you have to go ahead with it, but those patients still died. Within
that treatment is to be given even if you don't put a liver in there, because
Yes.
you're mechanically ventilating that patient, you're already giving fluids to that patient, so you may put them in trouble just with that procedure itself.
Yeah.
So they may end up in treatment without the liver.
yes.
Yeah.
So, I commend you on a wonderful talk.
Thank you.
Secondly, probably your whole division has changed how we managed it, because when Mo and I were starting, we probably had 2 cases a year in the OR, making phone calls, and the second note, the number of phone calls coming to your group has dramatically decreased after we put the new policies of screening.
Yes.
We didn't even do WME echoes when we first started routinely for measurements, and that has dramatically changed to the point where you see it very rarely. Now, I'm going to go back in time a little bit, because the question is, as you brought up, is what to do intraoperatively for these medium level ones that are okay, they have a high PA pressure, SVR isn't that low, that high, or vice versa, your SVR is a little on the higher side, but your PA pressure is pretty much normal. Should we go ahead and, we can give, Pascal in the OR and do that. We've done that before with some success. I think we're biased against it now because we were able to go ahead with it, but, once in a while, like that Bruno said, we have those cases where we thought it was high, wedge pressures that SVR was fine. We got SVR, we got
PVR.
PVR was fine, and the wedge pressure dropped, went down to about 15 or so less, and we got the CVP down low, and they look pretty good. But then once we go open them up, they just crash.
Absolutely.
And for those kind of cases, I think we give nitrate nitrate to try to decrease it, and so forth. The question is, should we even pursue those cases? And as you brought up, especially we don't do them anymore because we just don't get sent to ICU and dry them out and see what they really have.
Yes.
And I think that change in management has dramatically affected our overall outcomes associated with pulmonary hypertension.
Actually, I wanted Dr. Arish to mention about the study that we just finished as well from the data from your patients, guys. So we have to thank you for that.
We looked at the last 10 years of all the patients who've come to the pulmonary hypertension clinic after being screened for portopulmonary hypertension who met criteria by either echo and right heart cath, and there were 21 patients who, over the past 10 years, we've treated. 52% of them, so 11, were cleared for liver transplant. 7 were successfully transplanted. We compared our patients to the REVEAL registry, which Dr. Quddus mentioned is the largest registry. We are much more likely to use IV prostacyclin than they were in their registry. We're less likely to use orals. And what we actually found was we had higher survival than they did. It was statistically significant. Our survival, regardless of transplant status, was 71%. Over 5 years. It didn't change how often they were hospitalized. It didn't change whether they had decompensated liver failure and admissions for that. It didn't change the 2-year survival, but the 5-year was significantly different. And I think that's something that we can be proud of as a group, that we're actually doing better than the national standard for this.
I think we brought you guys in a lot earlier, so most programs were doing it surgeon-driven, I think.
Yeah.
Yes, yes.
Most were done by anesthesia.
The comment that I made earlier regarding the organ classification or the method of implanting or the amount of blood loss during the operation, has this been looked at in terms of the intraoperative hemodynamics that you showed? To my knowledge, this has not been talked about too much. And because if you come up with tangible recommendations for a surgical team of how to navigate the potential complexity of these patients, people don't talk about that a whole lot. But we know we do that mentally, and we allocate organs mentally, and the allocation system is not sophisticated enough to let you do that. You will have to pass on the organ, and then you lose your turn. I wonder if in our data, if we look at it, whether this is can be weeded out. Because you can come up with some observations from that data, I think.
There's only 21. You said there's only 21 we treated?
Yes.
So we have a relatively small number, so we're kind of stuck. I think we're stuck. It's a very, very small number.
But it's a rare complication of a rare disease.
Yeah, right. And that's a very small
I mean, it will be a descriptive of the hemodynamic events, and then see if there is any linkages you
Like
can
case
explain.
series.
Correct, correct.
Yeah.
Actually, the numbers are small. Even if you look at the case series that I
Correct.
presented, they're like 19 patients was the largest series they had.
Yeah. Yeah. Yeah.
I did not see any data pertaining to surgical technique.
And without having that knowledge out, that tacit knowledge never will get transmitted because it's all in our heads. And even if it's small, it's probably worth at least describing.
Definitely.
Any other questions for Dr. Quddus? Yeah.
So we use a cutoff of 12. We think after that we we question that there is some obstruction in the pulmonary circulation. I think we are a little bit more cautious than people at Mayo Clinic. So that's, and it will vary according to the technique that's used in the cath lab as well. For us, when we look at our data, a right transpulmonary gradient of 12, does help us sort out true arteriopathy circulation.
Popularity, by the way, so transpulmonary gradient would no longer be used as one of the parameters. It's going to be gradient because that controls the pliability and stroke quality.
Yes.
So again, we're going to be modifying
Sure thing. That's a good point. Incidentally, the series from Egypt, I believe it's mostly living donors.
Yes, it is living.
Yes, and diseased donors. So it's interesting to see whether that's any different from people who get implanted with a full liver.
Yes.
Yeah. Yeah. Any other questions? Well, thank you, Dr. Quddus. This was a
Welcome.
terrific
Thank
discussion.
you.